Second lecture, actually there are two only and not three, and I don't think انكم ممكن تستحملوني.
لا احنا نستحمل.
احنا نستحمل ادينا بس.
انا خليتهم بدل 3 2. ثاني محاضرة يعني maybe it's gonna be a little bit interesting. I don't know. It's about the surgery. How to go for pediatric cataract surgery as a general ophthalmologist. يعني احنا مش هنتكلم ك pediatric ophthalmologist. If you have a case of congenital cataract, how can you go for a very straightforward pediatric cataract case? How can you diagnose it? How can you treat it? Whether to go for surgery or not. I mean, you cannot measure the visual acuity. هل هي indicated for surgery? But I have to wait. So this lecture will answer these questions. Again, we're going to repeat that the congenital cataract is the most common cause of treatable childhood blindness. You can treat it and you can prevent blindness. And there are actually many questions and debates, and despite the major advances in microsurgical techniques, and despite the major advances in the instrumentations and the machines, still it remains a challenge. A challenge, for example, when we go for a down baby like that, when you go for surgery, okay, and then we're going to fit her by spectacles. There is a very short nasal bridge here that cannot be fitted easily with spectacles. You should choose the right frame and the right spectacles for this baby. And again, the aphakic spectacles is very thick and heavy. When you go for surgery for a few months baby, now there is what is called the lenticular lenses. It's very thin and light and can be easily fitted for these babies. And there should be a special design, panara spectacles, and it should fit properly over the ears of the baby. And there is a debate about the amblyopia therapy if you go for cataract surgery and IR implantation as early as 3 to 4 months. How can you calculate the IR power and actually what spectacles you're going to fit with, and the amblyopia therapy in these babies. And we should not forget there are 200,000 children blind from congenital cataract, despite it's not a difficult surgery to go for. And now we're going to discuss why are these babies blind from congenital cataract. The third thing is improper management during surgery. You are an adult phacosurgeon, you can go for cataract surgery in an adult, and you think that this is the same thing, the baby's eyes is just a small adult eye. No, it's not a small adult eye. The reaction of the eye is totally different. So there is a sort of improper management during surgery, and there is inadequate follow-up exams. For example, damaging the back surface of the child, despite we have a very high endothelial count in these child, causing corneal decompensation, leading to blindness. Secondary glaucoma and corneal decompensation in a microphthalmic eye. If you're not acquainted to go for cataract surgery in an infant, please don't go for it. Secondary cataract, corneal decompensation, leading to blindness. Eating up the iris with a cutter, secondary membrane, occlusal pupillae, occluding the visual axis, leaving the child severely amblyopic. Inadequate vitrectomy, we're going to see how we're going to go for vitrectomy. Inadequate vitrectomy here, these are vitreous strands going to the one, pulling over the retina, causing retinal detachment, leading to blindness. Secondary glaucoma, and sometimes it is so severe and blinding like that that it is inoperable. You cannot go for anything for these children. And sometimes the secondary glaucoma, the eye is lost, leading to anterior staphyloma, leading to blindness. If you don't take the certain precautions, as you're going to see, during disinfection and dealing with the child without any sort of systemic infection, you may face endophthalmitis. The eye will become like a bag of pus like that, leading to atrophy bulbi or phthisis bulbi, leaving the child not only blind, but with also total disfigurement. Delayed surgical technique, the second cause, that causing very dense amblyopia, leaving the child like that, a baby like that, she's 4 years old, with very dense congenital cataract since birth. leaving a teenage, this is a teenager in the teen and in the 20s with congenital cataract. They are totally blind from not having congenital cataract surgery. Maybe this guy had a congenital cataract surgery when he was young and it ended in retinal detachment and no PL. So they decided that all their children will be left with this congenital cataract and left in darkness. So there is very delayed surgical intervention. Actually, we did these children congenital cataract, but the concept that their father was totally blind from congenital cataract. He was not operated and left again in darkness. In these children, when we go for congenital cataract in this age, yes, we have clear visual access and everything is fine, but you will never have 6/6 vision because there is marked delay. Again, this is a mentally retarded child left with a bilateral congenital cataract until this age. However, this actually did encourage us to go for these surgery, to perform surgery in the teens, in the 20s, or even in the 30s with congenital cataract. This mentally retarded child here, after bilateral cataract surgery, her behavior changed markedly. So now we changed our concept and we go for the surgery whatever the age. This is 26-year-old lady. She came with one eye. This was lost during infancy from pediatric cataract surgery and a calcified membranous cataract. We actually gave it a try for this calcified cataract, and this is a tight well by here. And astonishingly enough, we did only cataract surgery without even IOL implantation to be of a minimum to go for a cataract surgery through 2 side port incision. Astonishingly enough, in this patient, the vision was 6/24 after surgery. It was a miracle for us. And this girl actually, I did her 10 years ago, and it changed the concept of not operating and not proceeding with the cataract surgery after the age of amblyopia. No, whatever the age, we go for surgery because actually her life changed markedly. Mismanagement. As we said, we cannot go for cataract surgery like adults. Leaving the posterior capsule intact may lead to pearl-type posterior capsule opacification, and sometimes the lens epithelial cells may undergo fibrous metaplasia, causing the fibrous-type posterior capsule opacification, leading to amblyopia. Here, a perfect cataract surgery, but it is done like adults. No polishing of the anterior capsule, and the posterior capsule was left intact, leading to posterior capsule opacification, and the child is amblyopic because he's not complaining. Using the terrible, and I say terrible, PMMA lens, which many surgeons use in children. Please do not use PMMA lenses in pediatric population. It may lead to inflammation, and this inflammation will turn out to be fibrotic posterior capsule opacification. Can you see these fibrosis behind the intraocular lens? And then the surgeon actually go for a very large one. It's like proceeding with an extra capsular. This is condemned. This is actually a big mistake to perform in pediatric age group. And sometimes the inflammation in the child is so severe fibrous reaction in the anterior chamber, leading to membranes in front of the IOL, necessitating secondary surgical intervention. This surgery was done like adults. The surgeon actually did a clear corneal wound, and he left the wound sutureless, like adults. What happened? Shallowing of the anterior chamber, very mild shallowing that occurs immediately after surgery. What happened? Did invite severe uveitis, and it ended into anterior papillary membrane, which is vascularized in front of the lens. Dealing like adults, performing a small capsulorhexis without polishing, leading to capsular phimosis. Again, severe anterior capsular phimosis requiring secondary surgery. Extensive membranes with extensive summary ring, leading to amblyopia again. If you don't follow the steps we're going to say, and implant just to go for irradiation aspiration and put a PMMA, see here the fibrosis did push the intraocular lens upward, leading to IOL decentration, leading to very high astigmatism, which is not amenable for correction, and leading again to amblyopia. Irrigation aspiration and putting a PMMA. See, the surgeon actually did a tear in the anterior capsule and then irrigation aspiration, and then he did the intraocular lens. That's it. A few months after surgery, the IOL is displaced and there is marked fibrosis. Sometimes the fibrosis is very extensive, pushing the optic into the anterior chamber, what is called pupillary capture. And these are IOL-related problems that is seen after pediatric cataract surgery, doing it as if you are doing it an adult surgery, leading to severe and dense amblyopia in children. We actually perform surgery for these eyes. For example, this is a pupillary capture and secondary cataract. This after removal of the secondary membranes and depositing the IOL. Yes, we have now a clear visual axis, but the vision will not be that good because of amblyopia. Here again, as a case referred with PMMA, decentered and secondary cataract, we did exchange the IOL and cleared the visual axis, but the vision was not and will not be 6/6 ever. Again, implanting the IOL in the wrong place. If you don't see any capsular support, don't implant intraocular lens. Leave a phakic, and then afterwards there will be a sort of fibrosis where you can implant secondary. Here the IOL is being just hung with this pupillary membrane. We cannot remove this IOL, but there is no capsular support, because then there is no iris whatsoever. We cannot implant even an artisan or iris claw lens. Can you see the IOL is just hung with a pupillary membrane? Another major complication and a major defect actually is not PMMA, the anterior chamber intraocular lens. This is a crime. If you don't see anything, please don't implant, but not ever implant the PMMA IOL. Why? Because few months after surgery, fibrosis will develop. See how extensive the fibrosis is? So he should have waited and then re-implanted in the posterior segment. Another crime, which is the anterior chamber intraocular lens with a very large, extensive wound. Sometimes we cannot treat it. We cannot exchange it. This is anterior chamber intraocular lens with extensive wound, and there is no iris even to implant an iris claw lens, so leading to blindness. Again, anterior chamber intraocular lens protruding through the cornea, out through the cornea, and not only leading to the complications that can be repairable, no, leaving the child like that in total blindness in one eye, or even total blindness in both eyes after a pediatric cataract surgery, which is not fair. So, we don't want to see these pictures. How can we deal with the case of a pediatric cataract? To start with, the indications for surgery. To whom are we going to go for surgery? If the child is old enough and he can appreciate the trajectory, if the vision is measurable, if it is less than 6/18. If we have a 6/18 or more, don't go for cataract surgery, because 6/6 without accumulation is not beneficial. 6/18 and the accumulation preserved in a child is better than 6/6 without accumulation. Secondly, if the cataract is total. If you have total cataract, whether bilateral or unilateral, immediately go for surgery, even if the child is few days old. But it should be feasible and it should be possible to put this baby under general anesthesia. So as soon as the baby is fit for general anesthesia, you should go for surgery. Another indication is obstruction of the central 3 to 5 millimeter red reflex on ophthalmoscopy. It means you go with a direct ophthalmoscope and you look to the eye. If you see that the red reflex is obstructed 3 millimeters or 5 millimeters, you can go for surgery. So this is the opacity. There is no obstruction of the central 3 to 5, so it's not indicated for surgery.
Whatever the visual acuity is?
That, of course, and we are speaking about a certain indication. But the visual acuity, why? In such a case, if it is the visual acuity is decreased, maybe there is an error of refraction, maybe inducing a lenticular problem here, causing an error of refraction with the baby with the glasses. But surgically, this is not indicated for surgery.
No, I meant for the central 3 millimeter, which maybe could be anterior and not affecting.
Yes, we are proceeding now. دلوقتي هقول لك anterior posterior.
No.
احنا دلوقتي we are speaking about the peripheral opacity like that. And I have the central 3 millimeter red reflex is perfect. And I don't have an error of refraction. No surgery. طيب, I have a central opacity, but it is small and tiny. Is this indicated for surgery? No. But take care. As you said, this tiny opacity, this one is indicated, and this one is not indicated. Yes.
Something anterior and something posterior.
بالظبط. This one is indicated because it is related to the posterior palm. This is posterior polar cataract. It's very near to the nodal point, so this is indicated. But this central opacity is not indicated because it is related to the anterior part of the lens. So it's not only the size, it is also the site of the opacity, whether anterior, central, or posterior. This anterior polar cataract is not indicated for surgery, but don't take it like that for granted. Have a look to the posterior capsule. Can you look here? There is another opacity in the posterior palm. Sometimes the anterior and posterior polar cataract are combined with each other. Here we are focusing on the anterior lens capsule, and here we are focusing only on the posterior lens capsule. You have to focus on both, anterior and posterior, to judge. Because if you look here and you diagnose anterior polar cataract is not indicated for surgery, no. Have a look to the posterior capsule. Maybe there is another opacity in the posterior part of the lens, so it's going to be indicated in this case for surgery. طيب, according to this does not obstruct the red reflex, so this is not indicated, this lamellar cataract, but this lamellar cataract obstructs the red reflex, so it is indicated. Sometimes I cannot judge. For example, if I have an opacity like that, is it indicated or not? So I can proceed with another indication, which is poor visualization of the macular area by direct ophthalmoscopy. What does that mean? I get the direct ophthalmoscope, and then through this opacity, I look to the macula and the fovea. If I can see the macula and the fovea properly, so the baby can see me properly, and shortly and focused. Pardon? Dilated. If the cataract is associated with strabismus, whether sensory esotropia or isotropia is indicated for surgery. If the cataract is associated with any type of nystagmus, it is associated. It means that the cataract is very visually significant since birth. You know from literature that these types of congenital cataract are not indicated for surgery. These are the anterior polar cataract, the sutural, the coronary, sutural cataract, the blue dot cataract. You know from the books and the literature, they are not indicated for surgery. Don't take this for granted and send the patient away. You are not indicated for surgery, and that's it. No. Anterior polar cataract may be large and pyramidal like that and affect the vision. So now it is indicated for surgery. Or maybe large and dome-shaped like that, but it doesn't meet the 3 to 5 millimeter red reflex. You have to follow these patients and don't send them away like that and tell them there is no surgery. You may use temporary pupillary dilatations, mydriatics, in order to see from around these opacities. However, by time, they may develop strabismus. She's now exophoric, and I got the picture while the eyes deviated like that. Why? At the beginning, it was not indicated for surgery, but now she developed, together with this dome-shaped opacities, subcapsular cataract. So the cataract may progress. The congenital cataract is not stationary, may change by time. And we have to go for cataract surgery in both eyes to save her vision. This is another baby with anterior polar cataract. It's a pyramidal one, and by time developed these subcapsular opacity. And this is another case that developed subcapsular opacity. So you should not ever drive away that this child became 13 years old with a cataract, a bilateral cataract, congenital cataract, and after surgery, the vision was just 6:36 because he had bilateral amblyopia. He had this is anterior polar cataract and subcapsular opacity that totally occlude the pupil in bright light. If you see a case like that in a